Good morning, dear colleagues. Today, we are going to discuss a very important topic that is one of the leading causes of mortality and morbidity in our country, postpartum hemorrhage. By the end of these two lectures, we have two lectures speaking about this topic. You should be capable of defining and differentiating between early and late postpartum hemorrhage, identifying causes and risk factors of postpartum hemorrhage, identifying symptoms and signs of postpartum hemorrhage and listing the laboratory investigations, managing postpartum hemorrhage immediately after delivery of the baby and before delivery of the placenta, how to manage postpartum hemorrhage immediately after delivery of the placenta, and how to manage the condition after 24 hours of delivery. This is a very important graph. This shows the causes of maternal mortality, which are either direct or indirect. The direct, that is related to pregnancy, related to a cause that is mainly during pregnancy, and an indirect cause that may be due to a causal association with pregnancy. For example, she's crossing the street and a car hits her. This is an indirect cause of death. The percentage between both of them didn't change over the past 20 years, where 65 or 66% of the cases are because of direct causes, and 35 or 34% of the cases are because of indirect causes. So, what are the main direct causes of maternal death? Unfortunately, number one is postpartum hemorrhage. And the percentage changed over the years, but it is still high, which is 20 cases per 1,000 live birth. And this is not a low percentage. So the main cause is postpartum hemorrhage. Other causes, we have antepartum hemorrhage, hypertensive disorders, sepsis, sudden death, ruptured uterus, obstructed labor, abortion, ectopic, and other various causes that may be cause of a direct cause of maternal death. This graph shows the main causes of maternal death, as we said, and we find that the postpartum hemorrhage is still the main cause of maternal death over the past 20 years. This is in the year 2013. I'm going to show you a graph in the year 2000, and you saw the previous table which showed us the causes of maternal death, and we find that postpartum hemorrhage is still the main cause of direct maternal death. This is the graph which was done in the year 2000 of Ministry of the Health, and they showed that the causes of direct maternal death, the main cause is still postpartum hemorrhage. 34% of the cases are dying because of bleeding postpartum. So now we spoke about the scope of our problem. When we speak about a problem that is the main cause of not just morbidity but mortality, so we must be very aware of why is it present and how to manage this problem. The main cause of death are unfortunately iatrogenic, where substandard care by practitioners carries more than 65% of the causes of the death. Lack of blood products care is another important cause of the substandard care, where the substandard care by obstetricians, dyes, and lack of the blood represent 95% of the causes of postpartum hemorrhage and maternal death. What do we mean by definition? What is postpartum hemorrhage? The definition is very important for registration causes and for proper assessment of the magnitude of the problem. Unfortunately, lots of cases will not be reported because they do not assess the amount of bleeding properly. So bleeding from the genital tract after delivery of the baby, what about the amount that we should speak about? Previously, it was designated to be around 500 milliliters in the vaginal delivery, more than 500 milliliters to say that it's a postpartum hemorrhage, and more than 1,000 milliliters in cesarean section to say that's postpartum hemorrhage. But actually, that was not practical due to the underestimation that is done for the blood loss by the surgeons. So we found that lots and lots of cases are missed and they are not properly reported. So a new classification, which is the more practical classification, depends on the clinical picture of the patient. So if the bleeding is severe to affect the general condition of the patient, this is called postpartum hemorrhage. Apart from the amount, whether it's a 500 milliliters amount, a 1 liter amount, a 1.5 liter amount, if the general condition of the mother is affected in the form of tachycardia or hypotension or the other clinical picture we're going to speak about later on, then this is called postpartum hemorrhage. So, what is the average blood loss during the process of labor? During the normal vaginal delivery, we're speaking about around 500 milliliters of blood is the accepted amount of blood loss. During a cesarean section, a primary cesarean section, we're speaking about 1 liter of accepted blood loss. If it's a repeated cesarean section or an abdominal hysterectomy, we're speaking about 1.5 liters of accepted blood loss. it's an emergency hysterectomy, we're speaking about an accepted around 3.5 liters of blood loss. This does not mean that this is not a case of hemorrhage or a case of starting affection of the general condition. So what we mean by accepted blood loss is that the patient needs a replacement, that the patient needs to be monitored properly, and that this is not the amount of blood that after it we say that there is postpartum hemorrhage or there is a hemorrhage. We mainly speak about the vaginal delivery and cesarean section because these are the average procedures that happen. And as we said again, the clinical picture is the main context we're speaking about. If the patient is starting to be affected generally, this is our cutoff point for defining postpartum hemorrhage. So, what is the classification of hemorrhage in the pregnant patients? If the patient loses around 15% of her blood volume, which is around 900 milliliters, because as we said, the blood volume of the pregnant lady is around 6 liters. So if she loses around 900 milliliters, this is class 1 of the hemorrhage. If she loses around 1.5 liters, which represents 25% of her blood volume, this is class 2 of the hemorrhage. If she loses around 2.1 liters, this is class 3. And more than that, when it reaches up to 2.5 liters, this is class 4. So what are classes? The class 1 of the hemorrhage, usually nothing happens to the patient. No symptoms occur because the patient loses the amount of the blood which was actually increased during the pregnancy. If class 2 occurs, the patient starts suffering tachycardia, tachypnea, orthostatic changes, prolonged hypothenor blanching, and narrowing of the pulse pressure. These are the signs we are going to start diagnosing that this patient is suffering from postpartum hemorrhage. And if you return to the previous schedule, you'll find that we're speaking about 1.2 to 1.5 liters of blood loss. Class 3 of the hemorrhage, there is overt hypotension, marked tachycardia, marked tachypnea with cold, clammy skin. Class 4, there is no blood pressure measurable, oliguria or anuria with absent peripheral pulses. And this is a very ominous sign and that the patient is entering in an irreversible stage of the shock. So after defining postpartum hemorrhage and knowing what are the classes of the bleeding that could affect the general condition of the patient, let's now say what are the types of postpartum hemorrhage. Well, actually, the types of postpartum hemorrhage are divided accordingly to the time of the occurrence of the bleeding. It may be early, within the first 24 hours, or it may be after the first 24 hours up till the 42nd day after the delivery of the baby. If it occurs within the first 24 hours, this is called primary or early postpartum hemorrhage. If it occurs later, after 24 hours up till the end of the puerperium, which is 6 weeks, it may be called secondary or delayed postpartum hemorrhage. So defining the causes or defining the timing of postpartum hemorrhage puts it in either the primary or the secondary postpartum hemorrhage categories. So what are the causes of mainly primary postpartum hemorrhage? The causes, number 1, uterine atony. What do we mean by uterine atony? Uterine atony, this is loss of the normal tonic contraction of the uterus that should occur after delivery of the placenta in order to stop the blood loss. So if the uterus fails to contract, this is uterine atony. The other T, you're going to find that it's 4 T's. The first is the tone, which is loss of the tone, uterine atony. The second T is genital tract trauma. If there is a trauma present in the perineum, in the vagina, in the cervix, or in the uterus, this may be a cause of early or primary postpartum hemorrhage. The third T is related to the tissues or the placenta, where there is third stage complications in the form of acute inversion of the uterus or an abnormal or incomplete placental separation, or a part of the placenta is still present inside the uterus, or a total placenta is still present inside the uterus, causing the primary or the early postpartum hemorrhage. And finally, due to coagulation disorders, which there is thrombotic problems or thrombosis problems related to either a inherited factor or an acquired factor of blood abnormalities related to bleeding. So let's start speaking about uterine atony. Why does uterine atony occur? In another form, is uterine atony predicted? And this is the main point we should come out of lecture this time, that lots and lots of causes of postpartum hemorrhage are preventable. Postpartum hemorrhage could be predicted. How? We're going to see at the end of the lectures. First of all, What are the factors predisposing to uterine atony? Number one, there is an over-distended uterus. So if the uterus is distended by, for example, a macrosomic baby, if it's distended by twins, if it's distended by multi-fetal pregnancy, not just twins or triplets or quadruplets, if it's over-distended by a fetus with a congenital malformation, this may be an over-distended uterus, and an over-distended uterus may fail to contract after delivery. There may be uterine muscle exhaustion from prolonged labor. If the patient suffered from a prolonged process of labor and the patient has been bearing down for a long time during the second stage of labor, this may cause uterine muscle exhaustion and uterine atony. Infection is a major cause of uterine atony, and you're going to find that also infection is a major cause of delayed or secondary postpartum hemorrhage. So you must guard against infection and you must treat infection properly. Functional or anatomic distortion of the uterus due to a fibroid uterus, for example, a low-lying invaded placenta or a placenta previa, or any other uterine anomalies, for example, a septum or a uterine or a vaginal or a cervical abnormalities that could may be present. Certain general anesthetics, for example, halothane or isoflurane, these are a type of anesthetics given during general anesthesia that cause relaxation of the uterus, and hence the uterus fails to contract. Or if the patient has a history of previous postpartum hemorrhage and a previous delivery, well, actually there may be a cause that was undiagnosed the previous time and may lead to postpartum hemorrhage for another time. So you find that lots of the causes of uterine atony are predictable. So if you find any of these causes during the pregnancy, you may predict that this patient may suffer from postpartum hemorrhage. What are the factors that they may predispose to genital tract trauma? If the patient suffered from precipitate labor. What do you mean by precipitate labor? Precipitate labor is from the start of the efficient uterine contractions till delivery of the baby, the patient has less or passes through less than 3 hours. So if there is a very rapid labor, this leads to overstretch of the genital tract and may lead to genital tract trauma, and especially if the labor was unattended. If there is an operative or a manipulative delivery, for example, if the patient was delivered by a forceps or by a ventouse, this may lead also to genital tract trauma. If there is malposition, and as we said before, that the malposition and specifically occipital posterior is one of the main causes of delayed progress during labor, or if there is a deep engagement of the fetal head, this may predispose to genital tract extensions and lacerations, specifically if you're going to do a cesarean section. If the patient has a previous uterine surgery, for example, a cesarean section, a previous cesarean section, or she had a myomectomy done before, this weak point of the scar that's present inside the uterus may predispose to a uterine rupture later on. What are the factors they may predispose to retain products of conception, or the placenta remains inside the uterus? If you have an incomplete placental delivery, if you pull on the placenta and the placenta tears with you and a part is delivered and a part that's remaining inside, and you improperly diagnose the condition. If there is previous uterine surgery with morbid adherence of the placenta on the site of the scar, this may cause also retained products of conception. If there is high parity, if there is an abnormal placenta on the ultrasound, for example, placenta previa, placenta accreta, accessory placental lobe, or there is placental abruption, this may lead to retained products of conception. What about the abnormalities of coagulation? As we said before, the abnormalities of coagulation may be an acquired or an inherited cause of the abnormalities of the coagulation. So pre-existing coagulation disorders such as hemophilia A or von Willebrand disease, idiopathic thrombocytopenic purpura, history of liver disease, or use of anticoagulants, these may be a pre-existing causes of coagulation disorders, and also they are predicted. So if the patient who has a hemophilia A or von Willebrand disease or an ITP comes to deliver, please expect that this patient may suffer postpartum hemorrhage. It may be an acquired cause during pregnancy if the patient suffers from thrombocytopenia with preeclampsia, for example, HELP syndrome, and HELP stands for hemolysis, elevated liver enzymes, and low platelet count. This is one of the severest forms of preeclampsia that may occur. If the patient suffers from DIC caused by abruptio placenta or chorioamnionitis, this is the second time we mention infection. So infection could lead to atony, as we said before, and it may lead to abnormalities of coagulation, as we were saying now. So now we spoke about what are the predisposing factors. What about the prophylactic measures? As we said, postpartum hemorrhage may be predicted. So during the antenatal period, you must recognize all the risk factors that could lead to postpartum hemorrhage. You must diagnose anemia at an early stage, because the presence of anemia, number one, may lead to atony. Number two, mostly will necessitate blood transfusion, and hence will decrease the chance of the patient to pass without receiving blood products. You must ensure iron and folic acid supplementation to correct any anemia present during the pregnancy. You should educate the patient regarding the following, which are anemia prevention, going to the hospital early in labor, seeking immediate medical attention if any vaginal bleeding occurs. As we said, infection may be prevented if the patient do not gain excess weight gain, because this may increase the possibility of a macrosomic baby. Obesity is one of the factors that may lead to postpartum hemorrhage. Properly managing the first and second stages of labor, and properly managing the third stage of labor, and properly delivering the placenta. So, during labor and delivery, you should identify patients at risk of developing postpartum hemorrhage. If the hemoglobin level is less than 8 grams per deciliter, you should cross-match at least 1 to 2 units of whole blood, even if the delivery is a normal vaginal delivery, or 2 units if it's a cesarean section, to be present and to be available if needed. If you return back to the causes of mortality and major morbidity from postpartum hemorrhage, you're going to find that lack of blood products was a major cause, causing more than 31% of the causes of morbidity and mortality. So you must be ready. Even if the patient does not need or does not take the blood products must be ready. Active management of the third stage of labor, which is administrating 10 international units of oxytocin IM with delivery of the anterior shoulder, performing controlled cord traction and performing uterine massage, and making sure that after delivery of the placenta, that the placenta is delivered completely. If the placenta is delivered incompletely, you must make sure that there is no remnants of the product of the conception still present inside the uterus. So now we spoke about the predisposing factors. We spoke about how to prevent or how to try to give a prophylaxis against postpartum hemorrhage. What about the diagnosis? If a woman is presented with excessive bleeding, begin the first aid management while simultaneously taking a history and performing a physical examination. Do not work in each step alone. You're working with an emergency. This is the main cause of maternal morbidity and mortality. So you must work promptly, and you must work within your team in order to try to save the life of this patient. So you start taking history from the patient, history if there has been previous postpartum hemorrhage before, history about the antenatal care, if she had a regular antenatal care, if there was any anemia, if there was any risk factors we just spoke about, if there's any problem related to the pregnancy, if the patient suffered of any antepartum hemorrhage during this pregnancy. You're going to start your general examination by measuring the pulse of the patient, by measuring the blood pressure of the patient, detecting if there's any tachycardia or hypotension or not, by seeing the general condition of the patient, by seeing if there's any pallor present with the patient, and then you're going to do abdominal examination and to see if the uterus is lax or firm. If you could feel the uterus, a firm body felt under your hand, so mostly this is not atony. You're going to measure the uterine fundal level, see if there's any abdominal tenderness or rigidity, which may lead, or we say that there's internal hemorrhage, which may be a cause of a ruptured uterus or a ruptured scar. If there's any scars from previous operations, that could indicate that this uterus is a scarred uterus and there is a possibility of ruptured uterus or a trauma to the uterine or cervical parts. You're going to do a local examination to assess the amount of the vaginal bleeding. Look for lacerations in the perineum, vulva, vagina, or the cervix, and determine whether the placenta has been delivered completely or not. Tachycardia and hypotension may be present without any evidence of excessive blood loss if there is internal hemorrhage and uterine rupture. And this is very important. So you could find there's no excessive blood loss through the vagina, and you find the patient class 3 or class 4 from the shock. In a patient with hypertension previously, so she's a known hypertensive patient with a blood pressure 170 or 100 over 110, and there's severe blood loss, the patient may become normotensive. So when you measure the blood pressure and you find it 110 over 70, and you find the patient tachycardic, don't think that it's just fear. The patient may be shocked, but the blood pressure did not fall because it was previously a very high blood pressure. So you diagnosed the condition. What are the investigations you're going to ask for? First of all, as we said, you have to be very prompt in the management of this condition. You have to shout and you have to call for help, and you have to ask your team for emergency aid in the management of this condition. Every minute is very important in the life of this patient. First of all, you have to put 2 wide-bore cannulas, and you have to withdraw blood samples of venipuncture in order to have a PBO grouping, and on the RH type, you have to cross-match at least from 2 to 4 units of packed RBCs or whole blood needed for the clinical situation. You have to withdraw samples for laboratory investigations in the form of complete blood count, bleeding time, and coagulation time. The first aid management, as we said, is shouting for help, inserting 2 wide pore cannulas, withdrawing the blood for the previous investigations we asked, starting intravenous crystalloid solution until the blood products are present in a fast drip about 1 liter per hour, with starting ecbolic drugs. Even if the patient is not an atonic uterus, you're going to find later on that it's a vicious circle. So if you start with bleeding because of a trauma, for example, this may lead later on to a coagulation abnormalities, and this later on may lead to hypoxia and atony. So you have to give ecbolics in all the conditions. Continuously monitor the pulse and the blood pressure every 5 minutes. Insert a Foley's catheter. You're going to understand later on that the Foley's catheter is one of the main lines of treatment in cases of bleeding. Why? Because the monitoring of the urine output is very important in detecting the level of saturation and the level of the perfusion of all the body. If the kidney is properly perfused and if the urine output is proper, which is around 500 milliliters per hour, then this kidney is properly perfused and this patient is not in a late stage of the shock. But if the kidney starts to become affected and there's affection of the perfusion of the kidney and the patient starts to become oliguric, this is the point we must be very, very worried about the condition of the patient. You're going to massage the uterine fundus to make sure that the uterus is contracted or it's starting to contract. Are the measures for minor postpartum hemorrhage where blood loss is around 1 liter without clinical shock? You have to have an intravenous access. You have to have an urgent venipuncture, as we said, with group screening and fluid blood count. You have to have a coagulation screen. You have to monitor the blood pressure, the pulse, and the respiratory rate. And you have to commence warmed crystalloid infusion before you start transfusing the patient to the operating room in order to start to diagnose what is the cause of postpartum hemorrhage. What about the measures for the major postpartum hemorrhage? Well, it's a bit different. Now, over here, it's an emergency. I know you have an emergency curriculum you're going to take in your 6th year, but I'm just going to give you a fast hint about it. You're going to work in an ABCD way, where A and B are assessing the airway and the breathing. Your C is going to evaluate the circulation. You're going to position the patient flat, keep the woman warm using appropriate available measures, try transfusing blood as soon as possible. Until blood is available, you're going to give clear warmed fluids. Initially, 2 liters of warmed isotonic crystalloids are going to be given. Further fluid resuscitation can continue with additional isotonic crystalloid or colloid solutions as succinylated gelatin. Hydroxyethyl starch is not better avoided because it may be predisposed to hyperviscosity and pulmonary edema and pulmonary embolism. The best equipment available should be used to achieve rapid warmed infusion of the fluids, because over here you're managing a very detrimental conditions. The complications are severe. We're going to speak about the complications later on, but in addition to death, there is a serious morbidity that may follow postpartum hemorrhage. The sequelae include adult respiratory distress syndrome, coagulopathy, shock, loss of fertility, and pituitary necrosis. For example, it's called Sheehan syndrome. Think about other complications that may accompany cases of postpartum hemorrhage, and we'll speak about it in the face-to-face session. This is the end of the first part of our lecture. See you again, inshallah, in the second part of our lecture.